Hello, this is Giovanni Campanile D. I am from the Sicilian Secret Diet Plan, and we are thrilled today to be interviewing and speaking to Dr. Walter Longo, who's a world-renowned expert on fasting. And he, in 2018, was named Time Magazine, named him as one of the 50 most influential people in healthcare for his work on the FMD, or the fasting mimicking diet. He's a director of the Longevity Institute at the University of Southern California, Leonard Davis School of Gerontology, and also director of Longevity and Cancer Program at the Italian Foundation of Cancer Research. He has written many books. Most of them are bestsellers, and he's also the author of The Longevity Diet, which is a classic book on lifestyle changes and diet for living well and long. Today we'll be speaking about many things, but we'll start out the conversation about his experience with Roy Walford and Biosphere 2, where a group of people stayed in an isolated environment for a prolonged period of time. And Walter had his one of his initial experiences in dealing and seeing what the effects of fasting is on people, and including his mentor, Roy Walford. What he has found is that with the fasting mimicking diet, it causes us to rejuvenate ourselves. In fact, the organs in our bodies during a fasting mimicking diet, which is a 5-day low-calorie diet, 1,000 calories day 1 and 800 calories day 2, 3, 4, and 5, very well programmed. And what happens is our organs actually shrink, and then during the refeeding phase, they grow, and stem cells are used to regenerate our own organs, which is quite fascinating. And it enhances something called autophagy, which is a way of our body eliminating used cells in our system, also precancerous cells. So our bodies are always creating cancer cells, and fasting, and specifically the fasting mimicking diet, has been shown to augment that process. It also has been shown, and we'll talk about how it lowers insulin, IGF-1, and leptin. He has traveled to Ecuador and studied the Ecuadorian dwarfs, which have a genetically reduced level of IGF-1 because of receptor issues in their genetic makeup. And these Ecuadorian dwarfs tend to live a long time, and they don't have a lot of diseases that are associated with IGF-1. We'll also talk about how fasting affects gene expression. University of Palermo in Italy did a study with it on depression, showing positive results. Valter is now involved in creating a study in Calabria, Italy, on 500 patients with a control group, FMD, or fasting mimicking diet only group, and FMD and longevity diet in a third group. And they're going to measure many different biomarkers, including sleep parameters, using something called an Aura ring. And then we'll talk about fasting mimicking substances such as rapamycin, spermicide, resveratrol, metformin, also the 5 pillars of longevity. And then finally, 2 people that he has worked with and has known personally, Emma Morano, the longest living person in Italy, and Salvatore Caruso, another very long-lived person in Italy, about his experiences with them. So with no further ado, we will now get to our conversation with Walter. Thank you. Okay, so we're thrilled to have Professor Walter Longo. And Walter, I've been reading about your work for many years, and I'm, Sandra and I use nutrition in our practice very much. So I know you were, just to start off, I know you were a student of Roy Walford, and he was in the Biosphere 2. He was like the first guinea pig for fasting, I think, right? So if you could tell us about that. That sounds like an interesting history in your background.
Yes. Yeah, not necessarily for fasting, but he was the first guinea pig for calorie restriction. And so people had been publishing about calorie restriction, which is something very simple. What happens to lots of organisms, but primates, let's say, if you reduce the calories by about 25% below the normal level, not excess level, but the normal level. And so he went to this place in Arizona called Biosphere 2. They were locked inside of this environment. And then eventually they ran out of food, or they had low food reserves. And so they had Walford proposed, why don't we do, he was the world leading expert on calorie restriction. And so he said, why don't we do a calorie restriction study on the 8 of us, right? And he talked them into it. And sure enough, I think he made the mistake of, he was the only one I think that really followed. I reviewed the data recently. I think he's probably the only one. He was much older than everybody else, first of all. But also, if you look at the weight lost by the others, they lost about maybe 10%, and he lost like 20-25%. Wow. So it looked like he was probably the only one that did full calorie restriction, and everybody else did a halfway version. But the results were spectacular. So the cholesterol went from like 185 to 125 total cholesterol. Blood pressure dropped to 90/60. Glycemia dropped to about 70. Fasting glucose to 70. Right. So really remarkable.
What was the period that they fasted? They reduced the calorie intake. Or what period that we're talking
about? 1.5 or so, or 1 and 3/4 of 2 years, right? So it was very long, right? It's a long period. Let's say over a year. Wow. Yeah, 1.5 years of some form of calorie restriction. So then, of course, these were all followed up by lots of clinical studies by many people on modern ones, let's say, or more modern ones on calorie restriction, and confirmed everything. But I always show that, and then I always show how Walford looked at the end of the 2 years. And then when I actually went there when they came out, and it looked terrible, right? So they all looked terrible. And so some of it, of course, was being locked in an environment like that. But I think a lot of it was also being calorie restricted for 1.5 years, right? And the restriction in the type of food, in the level of food, and the level of calories. So I think that I always thought there was the moment, it was 1993, I think it was the moment where I said, no, this is not going to ever work for people. I mean, some of my colleagues will disagree, but after 120 years of research on calorie restriction and almost nobody using it, I will argue that that's not going to happen. So we have to look for different ways to do it.
So this is what led you to think about this fasting mimicking diet, which is more sustainable?
Yeah, so the fasting mimicking diet, more sustainable, but I also always thought about this idea of shrinking and re-expansion, right? And in fact, even Ansel Keys back, in the 60s and 70s, they have shown that they start people, right? And in one of his studies shows that the heart was shrunk by about 41%, right, in size. So it's really remarkable, right? It's shrinking.
How long of time does that happen?
I think it was like 20 weeks or so of semi-starvation, things that we could never do again, right? I mean, this is like, if you presented this to a IRB panel, they will laugh at it. Right? It's like, there's no way we'll let you do this. But they did let them do it in those years. And it's really remarkable. So people just shrunk. And then in 20 weeks following that, they re-expanded, right? It's such a simple concept, which is exactly what we see in mice, right? So in mice, we see the liver, the lungs, the kidneys, everything shrinking during the fasting, and then, re-expanding after. So I always thought, wait a minute, how do you shrink like that? I mean, it could be cell size. A lot of it is going to be cell size, but a lot of it is probably going to be cell death, right? And then how do you re-expand? Well, if you re-expand, you have to regenerate at many levels, right? And so it was the calorie restriction idea, but also something that calorie restriction doesn't give you, because calorie restriction never has an extreme enough push and an extreme enough return, right? So it's this portion return, this the refeeding moment that is actually probably the most powerful of all, as we've shown in many studies in mice now, and we're starting to show in human clinical trials.
So what do you think is going on when the shrinking happens? Like, I'm fascinated by the heart, because we know that a lot of our patients that have heart disease and have a lot of visceral fat around the heart and around the arteries, and it's very hard to get rid of that visceral fat. And do you think that part of that shrinking is the visceral fat going away, or is it the actual myocardial cells that are regenerating?
Dying and then regenerate.
Yeah, I think both, right? So we're going to publish soon enough the effects of the fasting mimicking diet, and I just call it FMD, on liver fat, right? On steatosis. And so I think that probably this is happening in different organs. We do see effects on even subcutaneous fat, although not as large as what we see in the liver and in the gut. So yeah, so part of it is that, but also clearly, as we've shown, in our studies of heart resilience, part of it is going to be effects on the cardiomyocytes. So, for example, we treated mice with dobutamine, and they were much more resistant and much better able to recover if they were receiving fasting mimicking diet. If they're older and receiving fasting mimicking diet cycles, we've also shown in the past doxorubicin resistance and recovery. And so I think that it's pretty clear that the heart is protected in ways, is better protected, and there are some processes which we don't quite fully understand yet. Are they regenerative, or are they just resetting changes? We don't know, but certainly the heart becomes more functional and or more resilient.
Yeah. Well, I have had patients that I've used the fasting mimicking diet on I use some advanced lipid markers like ApoB, LDL particle number, and there's a number of patients I've used, a cycle once a month for 3 months, and I've seen some significant reductions in those biomarkers. And
Great.
Let's see what those biomarkers are about.
Well, ApoB mainly. I've seen a reduction in ApoB.
Which means what?
Well, it's
Listeners, what the...
ApoB is all the bad particles of LDL particles that cause damage to the arteries have an ApoB wrapped around it. So an ApoB is a remarkable biomarker. Not only is a marker of disease, but also it's causative in and of itself. So if you reduce ApoB, you're reducing risk. Some people think that if we had an ApoB of 20, average Americans are much higher than that. But if we had an average ApoB of 20, there'd be no heart disease. And so this is why it's quite remarkable that this can happen.
Yep, I think it's great. I mean, and we've shown, cholesterol lowering, blood pressure lowering. Interestingly, we did not show blood pressure lowering in patients taking medication for blood pressure, right? So suggesting that maybe it's going through some of we've shown in multiple trials, clinical trials, where they were not taking medication. So the type of patient, they may have a 135, 140 blood pressure. But in the hypertense group taking medication, we did not see a reduction in blood pressure, which of course was already regulated by the drugs, So, but it was interesting. Yeah.
So, what exactly? And if you could explain what the FMD, what the fasting mimicking diet is, and how do you do it?
Yeah. So the fasting mimicking diet is low calorie, low protein, low sugar, high fat, and it's a plant-based. I decided to combine the fasting mimicking properties, so having certain amino acids being very low, having the sugars being very low, and having the fat being very high, with the sort of longevity zones of the world. The southern Italy and the Okinawa and the Loma Linda, et cetera, et cetera. And I think it was a good idea, because even though people probably do it on average, let's say 2 or 3 times a year, most people that do it, I just think that having selected is very beneficial or nutrients that are associated with longevity and health span. I think that was a good idea, and we're starting to see some of the additional effects other than mimicking fasting.
So why 5 days? What is that number? Why did you pick that number? What made you decide, let's do this 5 days, a few times a year? And what is the few times a year? Who should be doing this? Again, what is the magic of all of this?
Yeah, so it takes about 3 days for people to get into a full ketogenic mode, right? So and let's say you hear a lot of people always ask me fasting is, this morning I got interviewed and they're like, oh, is fasting good for you? And I always say fasting is good, bad, and neutral, right? Because it means nothing. It's just like eating good for you. Yeah, some type of eating is good for you. Some type of eating is really bad for you. So I think that you have to go 3 days to get into a ketogenic mode. And then, and you saw, at least the first time, people are not happy in that, right? So then I thought the extra 2 days are really pushing the shrinking that I was talking about, like autophagy, cell death. For example, white blood cells by day 5 to 7 in humans are decreased in most people by about 20%, right? So now you're temporarily decreasing white blood cells, but not in a dangerous way, but you're putting them at the lower part of the range, and then as you refeed them, they go back to normal or even slightly elevated, right? We see that in people, and that's another way we're about to publish, the lymphoid-myeloid ratio seems to be shifted up, right? So the during, you have a decrease in lymphocyte, and after, you have a shift into a younger lymphoid-myeloid ratio. And so then you have these 2 days where most people don't care. Now you're in a ketogenic mode, so you're not hungry. You can sit down and watch somebody eat. And not for everybody, but for lots of people. So we wanted to really take advantage of the 2 days of full shrinking and full, okay, I'm okay. And lots of people by day 5, they say, I could go another 2 weeks, right? Not everybody, but lots of people say that. So that was important. And then it was also important to, of course, to lower insulin, lower IGF-1, lower leptin. So all these keep going down, increase IGF-PP1, increase ketone bodies. And then I think it was also important not to enter what I call the thrifty mode, right? So at some point, there's a New England Journal of Medicine paper that nobody seems to be aware of. Many years ago, they showed that if you take people, kind of like the Ansel Keys in the semi-starvation studies, eventually, and it doesn't take that long, it could even be 5 days of, the FMD, by the way, has 1,100 calories for normal people, has 1,100 calories on day 1, and then 800 on day 2, 3, 4, 5, okay? But so it's possible that even if you reduce that for 5 days, your body already is going to enter a thrifty mode. So why? Well, because if the body gets into a range that it feels like maybe we're going to run out of food, it doesn't look good at all. So then you enter a thrifty mode. And if you enter a thrifty mode, now your energy expenditure goes down, right? And that's a worst thing. It's a worst nightmare, especially because it's been shown that this energy expenditure reduction, which should be epigenetic in nature, right? So now you have a long-term switch. It could last years, right? So now you enter a thrifty mode, which potentially, not very many studies, but a number of clinical studies are showing this. Now, and including this in New England. So now you enter a thrifty mode, and it may take a long time to exit. So what happens is now you are forced to be so hungry all the time that you're going to regain all the way back and more, right? And that's what Ansel Keys also has shown, right? And I forget what they called it, but there is like an overshot to gain enough fat, not for the sake of fat, believe it or not, but for the sake of regaining your lean body mass. So the body is forcing you to eat so much, regain it all back, and then overeat so that your lean muscle mass is going back to where it was, right? Because it wants to make sure that you're not going to starve to death. So anyways, very interesting, right? So there's all these factors that are in, and then of course the feasibility. You go longer, in addition to this danger of entering the thrifty mode, and most people are not going to do it. So now you start on Sunday, you end on Friday. Yeah, most people that I know say, okay, if I feel like I need it, And of course, 72% of Americans are overweight and obese, and about 50% of Italians. And, so I think, the majority of the Western population is going to need to do things like this. And so I think the feasibility is also there, as we've shown now in maybe 15 clinical trials.
So it doesn't lower metabolic rate, and it doesn't result in sarcopenia or loss of muscle mass.
No, now 3 different studies, no loss of lean body mass whatsoever. And like one that we haven't published yet, we go against the Mediterranean diet. A Mediterranean diet by month 3 is by month 4 is 3 pounds of lean body mass loss, and by month 7 is 5 pounds of lean body mass loss, right? So so then it's also, and I mean, of course, I'm a fan of the longevity, not necessarily the Mediterranean, but the longevity diet, which is taking a lot from the Mediterranean diet. But at the same time, people have to be aware it comes, if it's done without the fasting mimicking diet, eventually it pushes your muscle mass down, and we're not the only group that has shown this.
So what you're saying is that if you do a diet that has a caloric restriction for long periods of time, you might eventually lose some muscle mass over time. Metabolism might change. But if you use the fast mimicking diet, and you'll tell us how often to do that, then you don't take the risk of losing muscle mass.
Yeah, I mean, the fast mimicking diet, now we're pretty sure, and it doesn't happen in mice, it doesn't happen in people, maybe 4 different trials all showing the same. Even the trials where we do, 4 cycles in 4 months, right? So you expect by then you'll start seeing the lean body mass being lower. In this trial, though, with 84 patients, we were actually, I tell you the truth, I was surprised that the Mediterranean diet will result in. So if we took people, and independently of what diet they were on, and we just switched them, by month 4 on the Mediterranean diet, they had lost an average of 3 pounds of lean body mass. And by month 7, they had lost an average of 5 pounds of lean body mass. So it's a switch partly maybe having less proteins, less amino acids, et cetera, et cetera, et cetera. It doesn't mean that a Mediterranean diet has to be associated with muscle problem. Of course, it's not. But it's true, though, that even though I preach, as you do, about the Southern Italian diet, it's true that the Southern Italians and the Italians in general are frail compared to the rest of Europe, right? So that means these poor diets of the past came at the cost of some frailty. Nothing that didn't allow him to live to 100, but certainly frailty that in some papers is shown to be about twice as bad as that of Northern Europeans.
So how's the longevity diet different from the Mediterranean diet? What's the difference?
Yeah, for example, the longevity diet, first of all, is age specific. So it basically says, after age 65, 70, the Mediterranean diet is probably a good one because it's got more variety, it's got more meats, it's got a little bit more of everything, right? The longevity diet is much more restrictive, so it's only fish plus vegan. And also fruit, fruit and vegetable. Well, fruit is very much limited in the longevity diet. And the longevity diet is not really about the Mediterranean. It's probably more about the Okinawan than there is about the Mediterranean. Although, certainly in all my books, we report on lots of the people from southern Italy doing extremely well with forms of this. But of course, this was 50, 60, 70 years ago when they were poor. And all they had was a little bit of pasta and lots of beans and lots of green beans, and that's all they ate almost every day. So I think that the longevity diet is closer to. Of course, the longevity diet is looking at epidemiology, is looking at clinical trials, is looking at what happens if you have the typical Mediterranean diet for 2 weeks. On protein, on IGF-1 level, and if you have longevity diet. But the longevity diet, you're going to have a much stronger lowering of IGF-1 compared to the Mediterranean diet. So I think that the complaint, of course, my complaint was the Mediterranean diet. It was about, something the Ansel Keys went to Salerno and observed, right? The longevity diet is something that 5 different pillars of science, including the centenarians, but not just the ones from Salerno, the ones from all over the world. If you put it all together, you get a pretty clear picture. And also Loma Linda, lots of the studies by Gary Fraser and other on the 7-day Adventists, I think they're very powerful in showing, and again, they come with pescatarian and not with Mediterranean,
Now, you mentioned a few times IGF-1 as a marker, and you want to explain to our audience what that means. What is this marker? Where we start with this marker?
Yeah, insulin-like growth factor 1, it is basically, so we study these people, we study these mice and these people that are deficient in growth hormone, right? So the mice are in growth hormone and growth hormone receptor, but the mice that are in people that are deficient in growth hormone receptor, they have in the liver, the growth hormone receptor controls the release of the insulin-like growth factor 1, IGF-1. So if you're deficient in growth hormone receptor, then your IGF-1 is going to be very low. And these turn out to be the longest lived mice in record longevity, the growth hormone receptor, they're called Laron mice. They live about 40% longer, and they also have only about 50% of them ever develop any disease, even though they live 40% longer, which is really, really remarkable. I always say, half of the NIH funds should be dedicated to figure out how does that happen, independently of what diet they have, right? So then we've been studying the people that have the growth hormone receptor deficiency in Ecuador, and they have extremely low IGF-1, and they clearly protected from cancer, protected just like the mice, protected from diabetes just like the mice, protected from cognitive decline just like the mice. And now we're about to publish on cardiovascular, and everybody said, yes, they're protected against all of these because they have more heart disease. And so we went down with a cardiologist, Marco Caneva from NIH, and myself, a cardiologist and endocrinologist, spent lots of time here in LA and down there, and showed that if anything, they seem to be protected against plaque formation and most cardiovascular risk factors and measurements. So that was very interesting. So then IGF-1, very important for growth, but maybe because we're loaded up with proteins all the time, we have very high, especially in the United States, very high levels of IGF-1, and that's not doesn't seem to be good at all. So
that this Mimicking diet that brings that IGF down.
Yeah, it brings IGF down, but it doesn't bring it fast, because at a certain point, and we just published a meta-analysis on this, so 120 to 160, 180 seems to be the range that you should maintain. People that have less than that, they seem to be doing fairly poorly. Now, the Larons have almost zero, very low IGF-1. So it may be that, in the doctor's office, if somebody shows up and they have a 55 IGF-1, the 55 IGF-1 is not the problem, it's the consequence of a problem. They could have systemic inflammation, cardiovascular disease, they may have cancer. So lots of things drive the IGF-1 down. It's not clear why, but lots of problems drive the IGF. So we think that the IGF-1 is not, low IGF-1 is not a problem, but it's a consequence of a problem.
And plus the IGF-1 should go up when you exercise and for cognitive function, like when you sleep, deep sleep also increases transiently IGF-1. That's a good thing, and that's difficult to measure.
Well, but those are two different things, right? And this was also the trick, I think, in the cancer trials, right? So there is systemic IGF-1 from the liver, and then there is autocrine, paracrine IGF-1, right? So what you're talking about is probably much more the autocrine, paracrine, brain-centered IGF-1, which these interventions are not bothering, right? So then you could argue the opposite, kind of like insulin, right? You could argue that by having lots of IGF-1 all the time, you're making the receptors everywhere in the body more resistant, like insulin resistant. And so now when the local IGF-1 is produced, it's not going to be able to function, right? And this is something that the pharmaceutical company, the 7 pharmaceutical company that come up with IGF-1 receptor blockers and saw it failing miserably, they didn't consider, right? So this was blocking IGF-1 everywhere. And so maybe in immune cells, for example, right? So could it be that now you're blocking the bone marrow IGF-1, local IGF-1 from stimulating more bone marrow cells, and now you're affecting the immune system effect on the cancer. Just to give you an example of the complexity that needs to be addressed. So yeah, so I think that, of course, local IGF-1 very important for learning and memory, but the systemic one may actually have a negative effect on. But the exercise might be good because now you exercise, say 3 times a week, it goes up. You stimulate lots of processes like periodic fasting, comes back down, and now you're not installing or promoting insulin IGF-1 resistance.
So talking about exercise and fast mimicking diet, during those 5 days of fasting, do you recommend exercising or not? What do you recommend for lifestyle during that time?
No, we recommend that people are active and be careful because, different people respond differently to the 5 days. Now, maybe 1 million people have done it, right? So we feel pretty good about, not getting reports of deaths. And people die, believe it or not, from fasting, right? I just got an interview by a French magazine, and they were reporting on one lady that did some crazy improvised fast and ended up dead. And we had the same in Italy. Actually, somebody followed by a physician that was asked to fast water-only fasting for 10 days and ended up dying of internal bleeding from, she had multiple sclerosis. And this doctor from Perugia had the bad idea of telling this patient, go home or to the hotel and fast water-only for 10 days. And that patient died. So, so I think that that's also a very important point to, to standardize and be very careful because it's very powerful. I always say, I challenge anybody, and it goes here too, to come up with an intervention of any kind. It could be a cocktail of drugs that is going to cause more gene expression changes in an organism than fasting, right? And I say this many places. I never get anybody to say, I think I'll challenge you with this, and I'll say that this cocktail is going to do more than fasting. That never happens. So if you have any ideas, we'll test it out.
So, but if I understand correctly, so you're saying still activity during those 5 days. Don't excessively do anything, but still be active during those 5 days, correct? Still.
Well, not necessary, right? So we have some people that say, that's why I was saying, careful, and you probably have to have a nutritionist, a dietitian, or a physician that understands it. Because some people say, I got to 5 p.m., I remember my brother, just to give you an anecdote. It gets to 5 p.m., it's like I had to go home and go to bed because I couldn't stand up, the first time. Then you get used to it. But yeah, so now you wouldn't want to tell that person or be physically active all day. You would say, just go to bed. That's okay. Go to sleep. And then you have all the 3-4 next months to be active in exercise. So that doesn't need to be. But yeah, lots of people are very active during the 5 days. They go walk for hours. Lots of people, you get both effects, right? You get the people that say, I couldn't stand up. And you get the people that say, I never had this much energy. And it's really the variability, which also tells us probably the responses are going to be variable. So then very different responses in different people. And some people can do it. Yeah.
It seems like a real impressive effect is on cancer. And I know you talk about differential stress sensitization and how it affects cancer cells and how it affects cells, how they respond to chemotherapy. I think, we'd like to hear more about that because I think that's probably the most profound effect that the fasting or the fasting mimicking diet has on disease processes.
Yeah, I would say the most profound is on aging, right? Markers and risk factors. And number two, I think, is diabetes in the sense of what the clinical data so far. Lots of it is not published yet, but we're starting to have a very consistent effect. So now the Heidelberg study just came out, and the University of Leiden study on 100 patient randomized is going to come out, and these are treating diabetes. And so now, and we have two more that we're going to publish. And so now it's 4 studies, and a group in Ireland published on prostate cancer patient, but also published on the effect on obesity and weight loss and A1C. So I think that's the most solid result is on diabetes. It's I think the drug reduction on diabetes was about 7-fold or so higher in the FMD group compared to the control group, right? So the
group on a drug that's 7-fold better if they did FMD than if they didn't do FMD.
It is 7 times more likely to reduce drug use than with the FMD than with the drug alone, right? And in both trials are showing it completely independent. One in Germany, one in Holland, coming up with exactly the same effect. Very strong effect on A1C, impressive. And then drug reduction in both trials that is in the 7-fold range compared to.
How long does that last? That effect?
One trial was 6 months, and then we don't know how long.
No, I'm saying if you do an FMD for 5 days, and it has an effect on glucose and hemoglobin A1C, and insulin, how long does that effect stay with you?
Yeah, we don't know. We don't know. So we know from the first trial where we also saw A1C drop, et cetera, that 3 months later, about 60% of the changes, significant changes that caused by the FMD were still there. But even already 3 months later, 40% disappeared, right? Or the significance. There were still trends, but so I would say, by 6 months, a lot of the effects are probably going to be gone. But the idea is to also bring patients in a sustainable and feasible way to a different level, right? So with weight, with liver fat, with abdominal fat, and so the idea is to do maybe 8 cycles on year 1, and then do I think 6 cycles on year 2, and then 4 cycles on year 3, right? So then the patient does have to look forward. Not only they can after 5 days they can go back to their diet, and this. Believe me, that surprised us. I mean, I thought obese diabetes patients, they're going to have a hard time. But in the Leiden trial, they went 12 cycles. Then the point is, yes, they're going to have to keep doing it, but they're going to have to do it less and less. And hopefully within 2 or 3 years, they're going to do it maybe 3 or 4 times a year. And that's it. And so it was remarkable that in the absence of any other advices, any other lifestyle changes, they could do it. And
that's amazing. Wait, does it affect their eating habits in between the FMD?
Probably, yeah. So we think because the ingredients are Mediterranean or very healthy longevity diet, I call it. I think they're probably also naturally starting to feel better on these foods. And by not feeling like, okay, now for the rest of your life, this is going to be your diet, but more like, okay, do it for 5 days. Don't worry. It comes in a box. Do the 5 days, and then you're going to go back. So I think it's just a way to get people to say, you know what, I felt better when I was eating vegetables and nuts. And yeah, so I think probably they gravitate towards a healthier, more Mediterranean or whatever type of nutrition.
I have 2 questions about that. You mentioned 8 cycles the first year, maybe 6, and maybe 3 the following years. And when you're talking about cycle, is like once a month, once every 2 months, every 3 weeks? So what do you recommend for people who have diabetes? And do you recommend different protocols for different diseases or weight loss? So would it be different? And then you mentioned it comes in a box. So I want you to tell our audience what you meant. It comes in a box.
Yeah. So so 8 cycles spread in a year, right? So that's the idea that the Heidelberg did the 6 cycles consecutive every month and then stopped. The Leiden did it for 12 cycles, but lots of them did not make the whole 12. And they were still benefiting very much from, let's say, 6 to 8 cycles. So that was the decision. Every different diseases, completely different. So for example, we just finished a trial in Alzheimer, or we're finishing. It's not finished yet. But in the Alzheimer trial done at University of Genoa, University of Perugia, is every month, but then we give them a supplement, a ketogenic supplement every day, 400 calories of it, right? So why? Because we were worried about the lean body mass loss, the calorie restriction. We did not want to calorie restrict Alzheimer's patients that are 80 years old, right? So we're doing studies on IBD, and now for IBD, we have a different, composition. That is trying to not promote inflammation.
Irritable bowel syndrome?
Yes, bowel disease, yeah.
Inflammatory bowel disease.
Inflammatory bowel disease, yeah. Inflammatory bowel disease. So, then cancer, for example, is 4 days, 600 calories, right? So in cancer, we try to go harder, but we want to finish it just to match a lot of the different therapy. We want to finish within 4 to 5 days. And that's why we do the 400 calories. And yes, so going back to your question about cancer, that's probably number 2 or 3. We're very excited. So Leiden again did a study with 125 patients, randomized, ER positive breast cancer women, and showed that the women that, well, first of all, and it was interesting because we got criticized for that trial. I'm just a middle author, so they got criticized. Let's say the clinicians, they get criticized because the compliance was fairly low, about 35%. There was 8 cycles of chemotherapy, with or without the fasting mimicking diet. And the incredible thing is, in spite of the low compliance, and the low compliance happened because, although they will never admit it, because they did not have properly trained dietitian. Dietitians, they were trained with this type of techniques, because the dietitian was trained in school to have people with cancer eat more, right? So now they see this and they're saying, what's going on? And we saw it here at Norris Cancer Center, right? They were like, no, come on, eat something. Right? We had nurses telling the people in the trial, eat something, while they were supposed to fast as part of the trial. So in spite of low compliance, it still worked in intent to treat, right? So the 2 groups, they were, I think, 3 times the women in the FMD arm, independently of how many cycles they did, and they did, let's say, on average 2 cycles, they were 3 times less likely to be resistant, to not respond, or more likely to not respond to the chemotherapy cycle, right? So, meaning that the FMD made it, went, I think, from 27% to 11%, I think it was. 27% non-responder in the chemotherapy alone, 11% non-responders in the FMD. Now, if you did per protocol, you actually look at the women that did all the cycles, it goes from 27 to 5%, right? So, and the really interesting thing about that trial is that the pathology, when they look at the slides, the pathology slides, it matched very well. There was a dose response in the women that did most cycles, or let's say all cycles of the chemo with FMD. The cancer-free, 90 to 100% cancer-free slides were much higher than in the women. So I think it was like from 50 went to 56% or something like that, all the way down to 5% in the women that did not complete any cycles of the chemo with the fasting mimicking diet, right? So it's a good start. And then Vernieri at the National Cancer Institute in Milan did a 100-patient trial showing in many different tumor types infiltration, immune cell infiltration in the tumors, independently of what the treatment was, right? So that was also very, very interesting. And
people that did FMD, they showed more infiltration.
Yeah, in people that the patient in the FMD, actually in this trial, all the patients did. It was not randomized. All the patients did the FMD, and they showed many patients with infiltration. And then they published a second paper, which I think was as impressive. And the second paper was titled something like exceptional responses in 5 patients in the same trial. Out of 100, the 5 among the ones that were advanced stage cancers had exceptional responses. So it was pancreatic, like stage 4 pancreatic, lung, colon. So interesting, right? Yes, it's an anecdote, but interesting that you will have 5 patients in the same trial that now are showing these exceptional responses. And
what do you think is happening? What do you think is happening there in these cells? Are these cells becoming more susceptible to the therapy? Is that what's going on? And how is that happening?
Yeah, so in the mice, we show it very clearly is basically making the cancer cell rewire. So the normal cells, they know exactly what to do. They go in a standby mode, starvation response mode, right? And they can go for 2 years. Most people can go 2 months. Most people can go, let's say, 1.5 to 2 months with no food, right? But the cancer cells, they try to rewire, right? They try to, in many different cases, they try to go back to the mitochondria from a Warburg type effect, right, back to the mitochondria. But of course, the mitochondria is no longer able to perform as it did, right? Because all kinds of mutations, all kinds of epigenetic changes. So what happens is the mitochondria start making lots of superoxide, hydrogen peroxide, etc., causing lots of DNA damage. And, in lots of cases, killing the cancer cell directly, but also, interestingly, making the cancer cells much more visible to the immune system, right? So now it's an immunotherapy-like effect, probably because of all these antigens being generated within the cancer cell and now within the normal cell, right? So, yeah, so those seem to be the explanations from the mouse work, but also from the initial 10 clinical trials that were already completed.
They're all at 600 calories for 5 days, so much more restrictive.
Yeah, most of them 600 or lower, right? Much more restricted for 4 days, or about 600 for 5 days.
Yeah.
Yeah, the box. You asked me about the box. So the box. So I started this, the first clinical trial in 2009 or whatever. It was water only fasting. And we thought all the cancer patients, of course, they're going to do it. And then that was not the case, right? So the cancer patient, they felt cheated. Why are you making me eat nothing? I can't do this. I have cancer. I'm already stressed out. We didn't expect that. We expected high motivation, high compliance. And the oncologists, of course, were as worried as the cancer patient, right? So then we went to the NCI and to the NIH, National Cancer Institute, National Institute of Aging of the NIH. And they funded research for the fasting mimicking diet, right? So we asked them, well, maybe we can develop food that people can eat in a limited way. And then in our initial discussion with the FDA basically say, if you want to be taken seriously by us, but even if you don't get an FDA approval, you're going to need to standardize, right? You have to say, okay, we tested it in 20 trials, and this was what we tested. And I remember one of the first meetings I had with one of the former FDA leaders, and I said, but we know how it works. That's what I said. And he said, no, you don't, right? So he was basically saying, well, what if you have one ingredient in there that's affecting the microbiota, that's affecting the immune system, that's affecting the cancer? You think it's a fasting. I mean, of course, I don't think it's true, but it could be, right? It could be right? It could be that there's one particular ingredient that is doing the trick, and it's not what we think is doing the trick. And so, so then the box is about standardizing, right? It's about saying, whether you're a normal person, you're a cancer patient, you're a diabetes patient, you're an autoimmune patient, we're going to standardize it, we're going to test it, and whether it's FDA approved or not, and we'll see, because the FDA is very expensive and the food doesn't necessarily need to be regulated if it's part of a lifestyle program, right? Like the Ornish program. So then the possibility is to do it with the blessing of the FDA, but not necessarily with the FDA. But it's got to be in a box. And I decided to donate everything to charity. So I don't take consulting from the company, and I don't take my shares eventually will belong to the foundation clinics and to the foundation for good causes. So
it's great.
Unfortunately for me, I don't make money from it. Yeah.
So you mentioned something about the FDA talking about the microbiome. That's an area that we're very interested in. And how does this affect inflammation and microbiome. I know those are two huge topics, but I'd like to have your opinion about that.
Yeah. So we did study mice on IBD, and as part of that study, we looked at the microbiota, and there was a big change, and surprisingly, it was much bigger when we used the FMD than when we used water-only fasting. And actually, water-only fasting caused a temporary increased leakage in the gut of the mice, versus the FMD, which never caused that. So it's possible that the signal of the FMD is the gut usually after long-term fasting becomes lighter, let's say, less cells, probably trying to in an attempt to save energy. And this doesn't seem to be happening as much with the FMD. But also the bigger effect, I think it was probably from prebiotics, right? The fasting mimicking diet contained a lot of prebiotic ingredients, which we think fed the lactobacillus, bifidobacteria, and all these other groups that we saw increasing a lot in portion of the refed mice. So in people we don't know yet, we suspect that lots of the microbiota changes will occur. And now Stanford is doing a couple of trials for IBD. University of Miami or Florida, Miami, I think, is doing a trial. So yeah, I'm excited. And our foundation is about to publish some work on a case series on the first, let's say, 10 patients. So we're excited about all these trials, and we'll see what happens. But we get some good reports, let's say, so far, anecdotes so far, but we don't know about the randomized trials yet.
Yeah, I've just anecdotally, when I've done this on some of my patients, I measure a lot of inflammatory markers, including OXPL-ApoB, which is specifically a vascular inflammatory marker, NCRP and MPO, myeloperoxidase, and I've seen those numbers reduce significantly with the diet.
Yeah, so I mean, it would be nice to like we did in the past, or we're doing for the foundation, to if you want to consider, to do a report on that, right? So if you have enough, to collect the data and get an IRB approval and report on it, I think there'll be a lot of people appreciating even if it was only, let's say, 10 cases or so. I know that in 2009 when we published the first 10 cases on fasting and cancer, lots of people, lots of oncologists, and were able to be motivated to at least do more trials and or do trials, and that's what we hope.
Well, a fascinating trial would be, there's a new test we're using. It's a CAT scan with contrast with artificial intelligence overread, where we can see with exquisite detail what's going on in the coronaries, including the differentiation between inflamed and non-inflamed plaque. So It's very interesting to see if that low-intensity inflamed plaque was changed with this sort of intervention.
Yeah,
There are many things that do that.
Yeah, it would be interesting to look at it. Yeah, absolutely.
The other thing I would be really interested in, if you know of any effect on anxiety, depression, focusing, concentration, cognitive function. As a child psychiatrist, I would be very interested. Also, I'm an adult psychiatrist, of course, so I see a lot of people with anxiety, depression, and adult ADD, not just during childhood. And you were talking about the positive effect of refeeding when you see improvement in the healthy microbiota, and we know that anxiety most likely and depression are very much correlated with a defective or healthy microbiota or lack of.
Yeah, so we actually published a paper with this group in Palermo, in Sicily, University of Palermo, on depression, right? And they were, they showed that in addition to the standard of care, the fasting mimicking diet seemed to do good for these patients, and they felt it was positive enough to do now a larger trial, which we're now planning with them. And also, I know that we got contacted by one of the VA hospitals, and they were telling us they'd be using it on depressed patients for a while. And finally, I met somebody running a clinic with depression on depression here in California, and he was saying they use it very frequently on their patients, right? So I think that still the beginning, but very interesting, probably or possibly because of this ketogenic rewiring of brain function, and maybe that somehow this ketone bodies or ketone body based metabolism is increasing the or affecting the depression pathways.
So the ketones you feel are signals for rejuvenation or going through improving cognitive function, and in that thought, what's your feeling about ketogenic diets in general? Like, really?
I don't think the ketones. I think the ketones are one of the players, but I think that the lowering of glucose, the lowering of IGF-1, and possibly the lowering and then increasing of glucose, the lowering and increasing of IGF-1, the lowering the autophagy followed by regeneration. I think it's a very sophisticated, very old program. And, I started my work on fasting 30 years ago with Steve Clark on bacteria, right? So we were starving bacteria, stationary phase. And then I went into Walford, but then I went back to starving yeast, right? So I went from starving bacteria to starving people to starving yeast. But the remarkable thing, is what convinced me to stick with starving, is this incredible effects that we will see. We could take bacteria and starve them permanently, or yeast, and they live a lot longer. It's like, how's it possible? Complete removal of food and never reintroduced it, right? But then also there was an opportunity to really see lots of these effects on autophagy, etc. And then I think that, the re-expansion, which probably has a little to do with ketone bodies, and a lot to do with just restarting embryonic-like programs that have the job to, if your liver now became 50% smaller, you got to re-expand the liver, and you might do it in 10 days, right? So how do you double the size of a liver in 10 days, or however long it takes? I mean, in 20 weeks, the heart was back to the normal size, right?
Amazing.
Yeah, right. You think like, no way. I mean, that is great.
What do you think it happens? Is it?
Well, I think a lot of it is the size of the cell. So it's just a lot of smaller cells composing the heart. But I probably also a lot of that. And if it's true, and we're investigating that now, then what does it mean? Does it mean that you're now generating new heart cells when you re-expand, right? Then you're generating 20%, 30%, 5%? I don't know, maybe none, right? Fine. But even if it was none, as you're expanding the cardiomyocyte or the cardiac cells, is it now a rejuvenated one, or is it still holding on to all the junk, right? So hopefully, and that's what we saw with the pancreas, we saw with lots of different systems, with the gut, right? We saw the shrinking, and then the re-expansion is clearly involving stem cells, and it's involving embryonic-like developmental programs, and some of the Yamanaka factor are actually coming up, and being expressed in adult cells, which you normally wouldn't see these early embryonic markers. So then the heart is definitely an interesting one. So what happens in the heart, and we'll see. But
yeah, we're going to be interviewing Richard Childs, who's the Assistant Surgeon General, and he's an expert on stem cells, and he's given us, I've talked to him about the research on stem cells and cardiac disease. So it'd be interesting to see, in patients that have cardiomyopathies, weak heart muscles for whatever reason, a heart attack or, viral infection, if, you do an FMD a few cycles, if their heart function actually improves, which would mean a stem cell effect, I would think, and it would be a remarkable thing.
Yeah, and we've done that already, right, with mice. So we have this cardiac model where we do ischemia, and unfortunately, the first time we did it, we see effects already, but we did not have a severe enough ischemia, and so that it's hard to improve something that is already going to improve itself, right? So yeah, we started so we're going to go back now and make it much more severe and create a heart attack essentially, right? So and then see, right? Then see what can we bring him back. But yeah, absolutely, we would love to do. I mean, as we've done for the kidney, right? So we start with people that have problems, but not too severe, right? So in the heart, it would be nice to start with people that are, they may have some ischemic damage, but not too severe, just not, because of course the fasting is a pretty severe intervention, and we're worried about acute effects, negative effects, right? So, but yeah, it would be really nice to collaborate and do a study on a group of people that may have some minor heart damage. And
there's a lot of those patients that have minor reduction in ejection fraction that are healthy enough to do a fasting mimicking diet. They could definitely do it, and it would be interesting to see, because if their ejection fraction improves, then if that's the only other, they could be their own control. It just as a proof of concept kind of thing, it would be very interesting.
Yeah, and in the mice, the ejection fraction improved in the old mice, and the recovery from the butamine, from cardiotoxin toxicity improved. So then at least in the mouse model, we are seeing these changes. So the question is, what about humans?
Yeah, that would be fascinating. What do you think about things like other modes of fasting, like Dr. Panda's work on time-restricted eating and that sort of thing? What's your feeling about that, and how does it tie in to your work?
I think that I'm always being very supportive of Satchin Panda's, like shorter. Lots of his trials are actually looking at about 13 hours, I will argue, of fasting per day, and I like that, right? I like that. I don't like it when it goes to 16 hours, because most people, and not because it couldn't work, but because most people with 16 hours of fasting, of time-restricted eating, so they don't eat for 16 hours a day, they will skip breakfast. And breakfast skipping over and over and over is associated with increased mortality overall, increased cardiovascular mortality and diseases, right? So not a good start, right? So I would say that I'm all for, let's say, 12 to 13 hours of fasting every day, but for feasibility reasons and these trials, and also gallstone formation, gallbladder operation and gallstone formation, people that consistently fast for 16 hours or more, and they seem to have more gallbladder operation, twice as high as those that fast for, let's say, 10 hours a day. And so I think overall, I always thought that you could possibly do it for 2 or 3 months. The chances there's going to be negative for you if you do it for 2 or 3 months, 16 hours, and then you switch to some of the other things that we discussed, like say 12, 13 hours a day of fasting, the fasting mimicking diet, the longevity diet, or a Mediterranean diet, or a Sicilian diet. So I think that that's probably one way to go. Use it to get to where you need to get, and then go and use something that is much safer. Yeah.
And you agree with no eating for 3 or 4 hours before bedtime?
Yeah, then no eating for 3 or 4 hours before bedtime. That seems to be a very good thing. That Satchin and now we're doing a study in Calabria with 500 patients, 3 arms, 1 arm control, and 1 arm fasting mimicking diet alone every 3 months. So we're being very ambitious here. And then the third arm, fasting mimicking diet plus the longevity diet. And so in that we have the rings, right? The Aura rings.
Oh, okay, good.
And look at sleep in a subgroup in collaboration with Matthew Walker at Berkeley.
Yep.
So we'll see what happens, but he's excited about it. We're excited about it. It's a large trial, right? So we're now starting to move. We get rejected so many times by the New England Journal of Medicine that now they say we got to be bigger studies, So now we're doing a big study.
Without patients is pretty good study.
And measuring what the like deep sleep and REM and that sort of thing. That's what you're measuring.
We're measuring everything. So we're starting with a population that's going to have at least one risk factor for age-related diseases, so high blood pressure, high cholesterol, high, pre-diabetes, metabolic syndrome, et cetera, obesity. So we're starting with people. The typical Southern Italians now is not healthy anymore because he's eating a Western diet, right? And so we're basically saying, can we bring it back to where they used to be? And of course, we know we can bring it back with the longevity diet plus the fasting mimicking diet. But can we bring it back just with the fasting mimicking diet? And then we measure everything like we do in all our trials. We like 100 different things, from CRP, IGF-1, BP1. We're doing telomere length. We're doing epigenetic clock, the sleeping pattern, et cetera, et cetera, et cetera.
Where do you put exercise in all of this, and what is the age range of these people that these 500 patients that you're looking at, that were you asking them to do for exercise?
Yeah, so exercise is not in there. We basically don't tell them to change nothing, right? So whatever you used to do, keep doing. And that otherwise it's just, we get to the end and we give them a lot of things, and lots of people are not going to be able to do a lot of things, and then it's going to be hard to assess them. And then we don't know what did what, right? So this is why we have a clean arm, just FMD, and then identical plus the longevity diet, and then the control, right? So then we'll know what did what, right? And but yeah, so exercise obviously it should be done, and we're all for it. But in these trials, it's just
ask patients not to do it. You just continue to do what you were doing.
Yeah.
And
well, actually, no, now I have to correct myself, because in the third arm with the longevity diet has implied in it 150 minutes a week of exercise and time restricted eating and lots of different things, right? So so then the longevity diet arm actually is also going to be told to do 150 minutes of exercise. It's more of a program, a lifestyle program in that case. So we're going with the sure thing, right? You do it all. And then we're going with the much harder thing. What if you just do every 3 months a cycle of the FMD, and we'll see what happens.
This would be a great group to do that CAT scan of the coronaries before and after.
We can set it up if you want. Yeah, we can set it up. It's in Calabria, but if you're we have hospitals nearby. So
if they do the CAT scan in Italy, because I've done this with other patients. They can do the artificial intelligence overread of the CAT scan here. So it would be something fascinating to see.
Let's do it. We'll have to do a subpopulation. We have to amend the protocol and include it. But it can be done.
Oh, good. We'll talk about that then.
Very good. So I have a question. Now we're talking about fast mimicking diet, all these diseases, and of course for obesity. And what about children? We have so many children now with obesity, with fatty liver disease at such a young age. How do we ask children to do this? Is it safe to do in children? Does it make sense to do it in, the fast mimicking diet with children? And do you have any information about that?
Yes. So we started a trial at Gaslini Children's Hospital, one of the best ones in Italy, for type 1 diabetes in children, but it's going extremely slow. And because it's inpatient, they have to check into the hospital. And then so everybody's been very scared since the early days about cancer patients or any disease, children with diseases, and the fasting mimicking diet. Now I think that we're closer to get oncologists to start, doing it with children, and also when we talk to endocrinologists and diabetes doctors, I think most of them are saying, sure, I don't see a problem. Like if you're gonna do it, like say 12 and older or 14 and older, most of them are saying somebody's overweight and they're 14 and older. I just don't see a problem in doing it, right? So. Yeah, so I hope that we talked to Michael Goran at Children's Hospital here. He's an obesity expert, children obesity expert, and he was interested. And so we just have to get some group to to be brave enough to do it. And I'm more excited about the children effect than in the adult. So I'm thinking in a child, they see how because the 5 days are gonna make you lose a lot of weight, right? And psychologically, it just gives you a short-term acute push, like, oh wow, it's working. It's not like, oh, what, in a year you'll see results. At day 5 you see the changes, and that's why we think that might get the child more enthusiastic, and then maybe the child feels so much better when they're on those 5 days that without anybody ever telling them you got to change your diet. Like we were saying earlier, they start saying, well, I don't mind the vegetables, right? Now they had 5 days of vegetables and nuts and things that they never eat, so it'd be probably difficult to get them to eat it. But I think if it's gonna be like the doctor order this, right? And so, and the food, I mean, of course anybody can eat it. I mean, this, it's not, ravioli, but that's okay. I think most children, it's not like giving olio di ricino as this intervention that used to be given to these oils that nobody could possibly ingest, right? That we had to ingest.
As a child,
You had to do it, right? Yeah. So it was terrible, right? It was like hell, but people did it, right? So this is nowhere near that, right? It's a soup, like a spinach soup and a carrot soup, and in a bar made of chocolate. I mean, so I think that most children can probably.
And plus, these kids, some of these kids have serious problems. Some. They have fatty liver, they're getting end-stage liver disease and liver transplants. So, it's an intervention for a serious problem. So I think if it's presented the right way and the child is talked to the right way with a good nurse and nutritionist and coordinator, I think, they could probably walk them through it for 5 days because it's such an important thing.
This could be like a daily call, right? The dietitian or the somebody in the trial makes to make sure that everything is okay. And so I think done like that probably.
And have parents, the parents have to be
monitoring and involved,
and they're convinced that it's an important thing for their child. And I think that's.
Be curious to see what happens to the mood of the child. That will we do again in improving.
We're very much open to, if hospitals, the children's hospital that might be interested that. But I think we'll get to do it here because I think they were very excited, just very busy, and we never get around that. And also Gaslini Hospital, they were saying, this is hard, but I think if we did it with normal children, they're just overweight and obese, it'd be 10 times easier, outpatient, 10 times easier. So I think they in fact they asked us if we can write the grant on the normal subjects here.
And what do you think about like substances that are like spermidine, there's resveratrol, metformin, pharmaceutical that are like fasting mimicking substances that help move this along? What do you think about these things? Do you think they're helpful? Do you think they're, things that you take, or do you recommend?
I think that, we were probably the first lab in the world that got rapamycin from Mike Hall in 1995 to test it on longevity. In fact, I know we were the first because Mike Hall was working in yeast. We were working in yeast, and he had discovered, Tor, right? So he sent it to us, and so we showed very soon that rapamycin extended the lifespan of yeast, right? This was about 1996, but we thought you're really interfering with in the middle of a cell, signal transduction network, and I always thought, is you give it to somebody in a complex system, you're going to have a problem, right? So and sure enough, we know rapamycin, for example, causes hyperglycemia, right? And we know metformin blocks oxidative phosphorylation in complex 1 and blocks gluconeogenesis. So I think that, I like what Neurobarzillai is doing. If you start with a population that is in the 60s and 70s, a high risk for cardiovascular disease, and so the metformin could be something that it's very useful. The problem I think we're gonna face it when we try to give it to a 35-year-old that is perfectly healthy, and where now you're gonna interfere with TOR signaling in all cells. If you think about it, it's very unsophisticated, right? And again, we've been working on this for a long time, so it's a complaint against myself too. But it's very unsophisticated. You're blocking something that yes gives you an effect, but is it going to be reasonable if 5% of the people, let's say they 60% benefit greatly, 20% neutral, and 10% or 5% are going to be experiencing detrimental effect? Is it reasonable? I don't think so, right? I don't think if you give it to 1 billion people.
I agree with you. Yeah, that's and this goes back to the whole concept. Where does it come from? What were we as hunter-gatherers? We probably went through many cycles of starvation. I always think about this as a cardiologist because we always talk about these markers like ApoB and LDL and cholesterol. Why are they elevated? Is it just diet, or is it because they're transport molecules and they're made to transport energy when we're in times of starvation, and now we're in the complete opposite? I don't know. You must have thought about this quite a bit. What do you think?
Absolutely. Like cholesterol is another one, right? I just heard the talk, and I want to hear your opinion. And down in Brazil, and this doctor from France was saying, let's look in the meta-analysis, was saying cholesterol lowering does not seem to have the effect that is being preached, right? And he was also saying something like, I didn't analyze the data, so I don't know. But certainly he's making the case with lots of New England papers analyze that maybe it's got a fairly neutral effect. And we've known for a long time, right? And longevity, people that take statins don't necessarily live longer. They may have less cardiovascular disease. And he was arguing even against that, right? But yeah, so why cholesterol is also very important for hormone generation for, the brain. And so could it be that now you're getting lots of positives and lots of negatives? And I think it's likely, right, that yes, you block cholesterol synthesis. And I remember a few years ago, somebody said, there's a new drug that is going to drive your cholesterol to 40. And so I'm thinking, yes, it might be good for certain things, but, what is it doing? This cholesterol is being made for a purpose. What's the purpose, And what happens when you block that purpose for 20, 30 years, right? Are you going to start seeing Alzheimer's disease increase, right? So I don't know, but certainly there is some studies going in that direction, right? It's showing problems. Yeah.
So do you think that our natural state is to go through the cycles of starvation or low calorie, eating excessively like at certain times of the year and eating much less in certain other types of the year? Do you think that, maybe, and I agree with you, I think that, something like the fasting mimicking diet, affects everything. It's not just one pathway, it affects the entire system. Yeah. So, maybe we're, mimicking what we really should be like, the low calories, because it's just a recent thing that we have so much food around us. That's, and in the history of mankind, we've been starving regularly. And so do you think that's why it may be effective, that it's replicating what we're naturally designed to do genetically?
I think that, yes, right? But I think also we shouldn't think that because it was old, like calorie restriction, right? It's going to be good for you. And people were always calorie restricted. But calorie restriction, the NIA monkey study showed that, even the monkeys that are calorie restricted, we're not doing better longevity-wise than the non-calorie restricted. The Wisconsin study showed so a calorie restriction against the Western diet was very effective. But calorie restriction against a decent diet was not effective at all, right? So just because it's old, just because people used to eat a paleo diet or used to fast doesn't mean it's good for you. So I think we need to say, yes, the fasting, refeeding is very powerful in doing lots of things, but we have to find out which fasting which refeeding, in which person, and how long, et cetera, et cetera. So yeah, I think that lots of these improvised interventions are going to be neutral to detrimental. And I think there's going to be instead a segment that are going to be incredibly powerful, like we're seeing now for diabetic patients, and we're seeing now with cancer, et cetera, et cetera. So if you do it, and for example, with diabetes, we're lowering drugs. With cancer, we're looking for more drugs to cure patients, right? So with cancer, we're saying, so we just published a paper where we had three drugs. One paper, we had 2 drugs, palbociclib and fulvestrant, plus the fasting mimicking diet. The other one, we had 3 drugs, and or even 4, palbociclib, rapamycin, picticillib, and another one. So yeah, so then, in some cases, you may have the sophistication might come from understand the mechanism, I'm going to intervene. So lots of people could say, well, can you starve a cancer, right? And the answer is, in the great majority of cases, absolutely not, right? The cancer steals from the other cells, and it does very well under starvation, right? Unless you bring the technology in, and now you block the estrogen receptor, you block CDK4/6 inhibitor, and now the fasting mimicking diet, which is lowering insulin, IGF-1, and leptin, now all of a sudden gets the cancer that grows, the hormone ER-positive breast cancer, and it gets it to regress, right? Unbelievable. And even with the triple negative, we could take a very fast-growing cancer and bring it back, right? And cure the mice. It's really remarkable. But my point is, if we just try the fasting, what fasting alone did, it reduced the cancer stem cells. But it would not prevent the cancer from taking over and killing the mice. And so, yeah, so I think that, sure, it's
not a cure. You need both the treatment and the fasting.
Not necessarily with diabetes, right? No, it looks like the cycles of FMD, it does it all, right? We bring it. We between the longevity
cancer. Yeah.
With cancer, the only exception so far has been some leukemias and lymphomas, right? And both we and what's his name at True North Clinic have looked at have case reports where patients, just before they're treated with anything, they're in this standby stage, they can control the certain leukemias with just nutrition. But that's the only time in both mice and humans where we see that. So beside that, and we couldn't even treat leukemia in a mouse with just fasting, right? But this group in Southwestern Medical Center, they published a paper in Nature Medicine some years ago, and they could just do it with just, So I think for very specific blood cancers, you can actually keep it under control, at least for a while, just with the fasting and a good diet. I mean, a combination of, let's say, longevity diet and fasting mimicking diet. But the other cancers, some of them don't even slow down. You could put all the nutritional changes you want, they don't even slow down. So yeah, but then you add the drugs, and all of a sudden, is a very powerful synergistic effect together, right? Even chemo, right? Say, when we looked at immune infiltration, you give breast cancer chemo alone, nothing. You give breast cancer fasting mimicking diet alone, nothing. You combine the FMD and the chemo, and all of a sudden you see the T cells, moving in the tumor and having a very strong effect. Right? So yeah, so the point is about mechanisms. It's about, yes, the past, but the technology is as important. You forget one of the two, and you're gonna have a problem. But you combine the two, and you sort of get the common denominator, and then you start seeing remarkable effects.
That's great. Very good. So I guess that we still have a lot to learn from this, right? That because it would be, you're talking about longevity diet, you're talking about fast mimicking diet, and we don't know if we recommend this, for healthy people, what happens to longevity, right? If you do a combination of both, whatever cycles you're going to do for the rest of your life, and does that change,
Yeah, and that's where
life, the longevity.
Yeah, and that's where you go, I think, to at least 2 of the pillars, or all the pillars, but certainly the epidemiological studies and the centenarian studies. And say, if you look at these people that we and others followed in Calabria, in Sicily, in Sardinia, and And it's just a group of people. It's not everybody in Calabria is long-lived, or in Sardinia or in Sicily. It's just a group of people. And if you look at what they do, and historically they had this very restricted, plant-based pescatarian type diets, or maybe a little bit of meat once a week, and then you look at the epidemiological studies and you look at the meta-analysis, and already you're starting to get a pretty good sense, right? So this Padnes, this Norwegian study that came out in PLOS Medicine just a few months ago, is looking exactly what the longevity diet is, and puts number one legumes, and also the Mediterranean diet. But I think it's more, it's probably going to be more restrictive, as we see for Okinawa, than the Mediterranean diet to get this, record longevity. But they were showing 13 years, up to 13 years increased life expectancy by having a high legume, high whole grain, high nut, high vegetable, no red meat, no processed meat, a type of nutrition against the Western diet, right? 13 years is a lot if you start at age 20, 8 to 9 years if you start at age 60, and 3 to 4 years if you start at age 80, right? So yeah, even though we cannot do longevity studies, I think if you put the 5 pillars together and you say it's safe, people can do it for a long time, centenaries have done it all over the world, epidemiological data is consistently showing that this is doing really good. Yes, I think you can't go wrong with this approach.
And it's a good diet. It's an interesting diet. I mean, it's we always tell our patients, live well deliciously. Like we want you to, the happiness, how you enjoy your life, is very important. Because if you try to be too restrictive, it's not sustainable. So
I agree. Yeah, I mean, it's got to be something that you enjoy. If it's too restrictive, you're going to abandon it. It's just a matter of time. And this is true for the ketogenic diets, very low carb diets, and that's also, we also know that, for example, people are demonizing carbohydrate. Now this carbohydrate turn, right? And for the last however many years, but it turns out in the meta-analysis, in the studies of all studies, that it's better to have an 80% carbohydrate diet than a low carb diet, right? For longevity.
Right.
This is in Lancet, right? So yeah, I think
in Sardinia, the longest living men in the world have a 70% grain diet. It's all carbohydrates.
And the Okinawans used to have a 70% purple potatoes, sweet potato diet, right? And so then and also it's interesting though, in the southern Italy, we're observing this pattern, which makes sense, right? So up to 70, 80 years of this very restricted diet, and then they move in with their sons and daughter, and they start eating much more, right? And we think this could have been the trick, right? Of Sicily, Sardinia, Calabria, certain regions that, well, first of all, they were genetically predisposed. Then they get this great diet, very restricted, and then they turn 80 and they get their sons and daughters say, eat more meat and eat more this. And, like Emma Morano, who I followed for the last 5 years of her life, and she became the oldest person who ever lived in Italy and the third oldest person who ever lived in the world. She was eating 150 grams of red meat, raw meat a day, right?
Raw meat.
Most people don't know she started this at 100, right?
Oh, wow.
So because Carlo Bava, the doctor, was worried about her becoming anemic and, and lots of other problems. So he said, you know what? I'm less worried about cancer and more worried about you dying of pneumonia. And so that's what he did. And he may have very well kept her alive for another 17 years. And, a true record historic. I mean, imagine that, right? The oldest person who's ever lived in Italy. That's a pretty big.
Was she the smoker? Was she the one? Oh, no. Because I remember one of these women.
That's Calmont. That's Madame Calmont. Yeah. It's French. Yeah. Yeah. This is why I always show Salvatore Caruso was in Calabria, was very, ate well and did everything right. And then I always show after, Madame Calmont, who was smoked until 117, or Emma Morano, who ate meat, 3 eggs a day plus meat until she died.
So you think that the restrictive diet for most of her life, and then at the end where she liberated her diet, was a good thing?
Yeah, but in her case, at 100, it was the red meat. Probably the red meat could still be minimized. Let's say a 75, 80, 90. And then, maybe after 100, then that's going to be such a high nourishment ingredients from red meat. Maybe the steroid hormones and everything else in it might actually help the patient. Yeah, but I would say that
because the protein, because a lot of older people don't eat enough protein. It could be.
Yeah, the protein, but it may also be just high nourishment. That red meat is going to have lots of different, the iron, the B12, so lots of ingredients that the 90-year-old, the 100-year-old may not be able to get enough of. So we did an experiment years ago, and we took mice that were young, and we severely protein restricted them. And they, no problem, for 30 days, nothing, right? 4% protein diet, which is extremely low. And then we took the same mice, identical, were 20 months old or so, and within days of 4% protein diet, they start losing weight very rapidly, right? So yeah, then the means that the same exact identical amount of protein and amino acid is probably not sufficient for an older system, which might not be able to utilize the amino acid as efficiently as before, or might not have growth factors and et cetera that are sufficient to implement protein synthesis.
But if she did that her whole life, she may not have ever made it to 100. And maybe that's...
Yeah. Well, I mean, all the studies will suggest that, right? Yeah. You never made. She will have died of many diseases before that, especially, 150 grams of raw meat per day, right?
Right.
This is a fascinating topic that I think there is so much more to learn and to talk about, that we could probably talk forever about this, and there's so much more discovery to do. So I want to thank you very much for being here today with us. Has been a humbling and rewarding experience.
Yeah, you're very generous with your time. We appreciate it. We could go on and on, but we don't want to keep you. Yeah. Hopefully we can do this again sometime in the future.
Sounds good.